And there are a lot of different autoantibodies that we see in juvenile myositis, and they can be broken down into two types. So those that are specific to this disease, called myositis specific autoantibodies, or MSAs. And these are autoantibodies that are only seen in patients with myositis, no other diseases. Patients almost always only have one or none, and they're present in about 70% of kids with myositis. Or you could have an autoantibody associated with myositis, and this is called a myositis-associated autoantibody. These are autoantibodies that are seen in myositis, but they're also seen in other autoimmune diseases. They can be found alone in a single patient, they can coexist with a myositis-specific autoantibody, or they can coexist with other myositis-associated autoantibodies. And you can see the list on the right is very long for both of these groups. And I'm going to go over them individually, especially the myositis-specific autoantibodies. So these are the main myositis-specific autoantibodies that we see in kids that have myositis. And the three most common ones are the ones in the box that I've listed here. So anti-P155-140, anti-MJ, and anti-MDA5. And the other ones occur in kids with myositis too, but are much less common. And as you can see here by the pictures, is they all go along with different clinical features. So most of the time, these kids have features of disease that can be grouped together based on their autoantibody, and then we can kind of understand what their disease might look like. And they occur in different percentages too. So these again are the three most common that were in that box in the prior slide. Anti-P155-140 is the most common in about 23 to 30% of juvenile patients. Anti-MJ is the second most common in 12 to 23% of kids. And anti-MDA5 is the third most common. And this percentage here, it has a pretty wide range of 7 to 33%. And that's because it geographically varies. So that 7% is from US and European studies, whereas the 33% is from Japanese studies. So it's much less common in the Western Hemisphere, but still more common than the other autoantibodies that we see, such as anti-synthetase, anti-MI2, SRP, and HMGCR. And we can break down these autoantibodies into groups based on disease features, so what patients have. So this chart is actually describing autoantibody groups based on adult data. So adults with myositis have autoantibodies that are the same as children, but they occur in different frequencies. Some are more common in adults and some are less common. And they also have some semi-different features, but there's a lot of overlap. And I'm going to go into these individually, so don't be overwhelmed by this chart, but I do want to point out a couple of things. Malignancy is on here, meaning cancer. That does not happen in kids, but does happen in adults, especially with the TIF1 gamma autoantibody. And statin exposure is another thing that happens in adults and can preclude autoantibody of HMGCR, but that's not seen in children. And then this is another way that we look at autoantibodies. So breaking it down by kind of what disease group. So we have three different groups here. We have kids with dermatomyositis or JDM. These are kids that have the typical muscle weakness along with the typical rash that is seen in JDM. And you can see here the most common autoantibody is anti-P155-140 in this group. But there's also kids that have JPM, so this is juvenile polymyositis. It's the classical muscle weakness without the rash. And you can see the percentages of different autoantibodies that occur are very different than in the JDM group. And the last one is juvenile connective tissue myositis, and again, different percentages. So we know these autoantibodies are occurring at different rates depending on kind of what type of disease you have. So the first autoantibody I want to talk about is anti-P155-140, and this is also known as anti-TIF1. Again, this is the most common myositis-specific autoantibody in kids and about 23 to 30% of children. And it's particularly in those with dermatomyositis or overlap myositis. So those with rashes or those with an overlap disease with myositis and maybe another autoimmune disease. And the target of this autoantibody is transcriptional intermediary factor 1 or TIF1. And this is part of a gene family that regulates signaling cascades and cell growth. But again, we don't really know if it's directly targeting that specific gene and causing damage in any way. We just know that that's the target of the autoantibody. So patients that have this autoantibody more commonly have photosensitive rashes. And I want to make a disclaimer before I go into each of these autoantibodies. I'm going to talk about the disease features that go along with each one of them. That doesn't mean that all patients with this autoantibody will have all of these disease features or even any of them. This is just the most common features that we see in kids with these autoantibodies. So they can have the classic Gottron's papules, like you can see here in the picture, the rash on the knuckles and overlying the hands that is red and you can feel it. Or the heliotrope rash, and this is the violaceous discoloration over the eyelids with maybe some dilated blood vessels that you can see here. A malar rash or a butterfly rash is also common in this group that you can see here on this patient. V and shawl sign rashes can occur in this group and are not as common in other groups. And so this is a rash that makes a V pattern on the chest or over the back, almost like a shawl covering the back. Linear extensor erythema, which means the kind of dorsum of the hand is red, and it doesn't just involve the knuckles like those Gottron's papules, it extends throughout the fingers there. And then they can have changes in their nail folds. And so periungual just means near the nail, and capillary are the smallest blood vessels that we have. And so they can have changes in those blood vessels. So you can see on the left, there's a normal nail fold, and all those blood vessels are lined up in a row. They're nice and straight and even, they're equally spaced apart. And you can see the abnormal ones on the right. They're kind of tortuous and dilated, and they're not a nice, even pattern. Patients can also have skin ulceration, and they can have lipodystrophy and lipoatrophy. And so this is abnormal fat distribution or fat loss, and it can be a late finding in patients with this autoantibody, and is typically associated with more severe disease and more chronic disease, and can even have metabolic abnormalities go along with it, such as insulin resistance and diabetes and even high triglycerides. And this is a picture where you can see, and this patient's skin is kind of sucked in right here, and we have some swelling here and a little bit of fat loss here. It's a very characteristic look of lipoatrophy of the face. So children that have this autoantibody more often have a chronic disease course, but not always. And in adult patients, this autoantibody is associated with the development of cancer, but this is not seen in children with this autoantibody. The next autoantibody is anti-MJ, which is also known as anti-NXP2 autoantibodies. Present in about 12 to 25% of patients. And again, most often patients have dermatomyositis, so the rash and the muscle weakness. It's reactive against a protein called nuclear matrix protein, NXP2. And this protein is involved in the structural organization of chromatin, which kind of organizes our DNA, and the integrity of the nucleus. Children with this autoantibody more frequently have cramping of their muscles. They might have dysphonia or change in voice, and they might have joint contractures where they have inability to really move their joints around. They're stuck in place. They typically have this characteristic rash on the knuckles, the Gottron's papules, and the butterfly rash or malar rash over the face, but they don't really see the rashes on the trunks like they did in the P155, 140 autoantibody subgroup. There are also a few reports of calcinosis, and so this is calcium deposits under the skin in these patients, and more frequent reports of muscle atrophy or kind of smaller thinning muscles in these kids. Again, children with these autoantibodies are more likely to have a chronic disease course, but not always, and they may have more severe illness. So there have been more reports of more frequent hospitalizations with this autoantibody group, and even reports, as you can see in the picture here, this is showing an ulcer and some bleeding of the GI tract. But these are pretty rare case reports, just more frequent than the other subgroups. The third subgroup is called anti-MGA5 autoantibodies. It was actually originally described in Japan and then found elsewhere in the world globally. And in children, as I stated before, the percentage of this autoantibody varies geographically. So in the Japanese population, in kids, it's about 33% that have these autoantibodies, whereas only 7 to 10% in the US and other European countries. So this autoantibody was also previously known as anti-CADM140, which stands for clinically amyopathic dermatomyositis 140. And the reason why is that it was originally described in adults, and in these adults, they did not have any muscle involvement. So in adult patients that have this autoantibody, they classically have little muscle involvement. And the same is actually not true of children. Children much more often have muscle involvement with this autoantibody. The target of this autoantibody is called MGA5, which stands for anti-melanoma differentiation associated gene 5. And this is a protein that deals with viral RNA. So when it sees RNA from a virus, it kind of targets it and then tells the body to start producing type 1 interferon and regulates the expression of that, which is kind of a downstream way to start causing more inflammation to target that virus. The features of this autoantibody include very pronounced skin disease, including ulcers of the fingers and other parts of the body. Patients have something called palmar papules, where they get little dots on their palms. They can have arthritis and joint pain, and they more often have interstitial lung disease. And again, in adults, they have minimal muscle involvement. So these are some pictures of that cutaneous ulceration, so ulcers in the skin. It can be, as you can see here, in the fingertips or overlying some of the Gottschalk's papules of the hands, or it can be on the elbows or knees, more common in this patient population. And it's a predictor of patients developing lung disease, especially in adult groups. They also can have, like I said, palmar papules. So these are little rash dots that you can feel on the palms, and they can be red or pale. They can present even as a flat macule or patch, so that's something you can't feel. They can also develop ulcers over them, and they're often painful. And then the bottom picture, this is rare, but patients can also get an occlusive vasculopathy. And so this is where the blood flow to their fingertips is so damaged and poor that they actually get necrosis of their fingertips. Now, these are all very severe, very rare findings, and I believe these pictures are of an adult patient. Anti-MGA5 is a little unique as an autoantibody because it can actually be used as a biomarker. So this isn't done clinically so much, but in research, the data has shown that anti-MGA5 autoantibodies are higher when disease is active, and then can become lower or even non-detectable when disease is inactive. And they can even be prognostic of patients that can respond and not respond to treatment. So the second graph is showing the level of these autoantibodies in patients that responded to treatment was lower at diagnosis than the level of patients that didn't respond. They had higher autoantibodies at diagnosis. Anti-MI2 autoantibodies are not as common. They're in about just 3 to 10% of those with juvenile myositis. They're often described as the classical dermatomyositis. So this is the patients that have classical rashes and muscle weakness. And these patients actually do quite well. They do have higher levels of muscle enzymes such as creatine kinase, and they can have higher muscle biopsy scores, meaning that they have more damage in their muscle biopsy, but they are usually very treatment sensitive, meaning they respond well to treatment, and they're more likely to be in remission and off medication 2 years after diagnosis. Anti-synthetase autoantibodies are also less common in juvenile patients. So they're present in about less than 5% of kids, and kids tend to be older at diagnosis when they have these autoantibodies. This is actually a group of autoantibodies that target amino-acyl tRNA synthetases. So tRNA is the type of RNA that helps us convert RNA into protein, and these autoantibodies are targeting that mechanism. Again, not knowing if they're actually causing damage or if that's just the target of them. As I said, these autoantibodies are less frequent in children than adults, and they are more often seen in patients with polymyositis or overlap myositis. Anti-Jo1 is the most common of the anti-synthetase autoantibodies. And children and adults with anti-Jo1 autoantibodies more frequently have a combination of symptoms that can be collectively described as anti-synthetase syndrome. And so this is interstitial lung disease, arthritis, Raynaud's phenomenon, where the fingers change color, fevers, and mechanic's hands, which you can see here, described by these kind of rough sides of the hands here. And patients with these autoantibodies more often have a chronic continuous disease course. So anti-SRP autoantibodies are extremely rare. They're only seen in less than 2% of juvenile myositis patients. And these patients much more often have polymyositis, so no rashes. There have been reports that they're more commonly seen in African American girls, but again, as the percentage of these autoantibodies are so low, I think we need to take that data with a little grain of salt. And juvenile patients with anti-SRP autoantibodies are typically older, a median age of 15 years. These autoantibodies are less than 2% of juvenile myositis patients, and they're associated with a different type of myositis called necrotizing autoimmune myositis. And so in this type of myositis, the biopsy is really not typical of what we see in classic dermatomyositis. Instead, patients will have a necrotizing picture where the cells are dying. So the cells are dying, they're degenerating, they're regenerating. It's not in a pattern or in a location that's typical of other kids with dermatomyositis. And so it can be very difficult to diagnose, especially if physicians are not familiar with a necrotizing autoimmune myositis. Kids can usually have very severe weakness. They have frequent falling episodes, they need wheelchairs, and they have very, very high creatine kinase levels. Cardiac involvement has been described in this population, as you can see by the little heart here in the picture, but this association remains somewhat unclear, again, because these numbers are so low that we're looking at. And patients in general have a more chronic illness and are more refractory to treatment, so harder to treat. Anti-HMGCR autoantibodies are the other type of autoantibodies that are seen with this necrotizing autoimmune myositis. And these are even more rare. So less than 1% of myositis patients have these autoantibodies. And again, the muscle biopsy shows that picture of the muscles dying, degenerating, and regenerating. Does not look like that classic dermatomyositis muscle biopsy that we see. These patients actually can have rashes that we see in other juvenile dermatomyositis kids, and they can have distal weakness, not just proximal weakness, which is a little atypical. In adult patients, these autoantibodies are associated with exposure to statin therapy. So adults taking statins to lower their cholesterol have been described to then go on developing these autoantibodies and the associated myositis with them. But children that have these autoantibodies do not necessarily have exposure to statins. There has been a genetic link in these autoantibodies to class 2 MHC DRB10701, which is a little unique of this autoantibody population in children. And then the last thing I want to talk about in terms of the different autoantibody groups is myositis-associated autoantibodies. And so again, these are autoantibodies that are seen in myositis, but they're also seen in other autoimmune diseases. What's really important to remember is that if a patient has a myositis-associated autoantibody, it doesn't mean that they shouldn't go on and be tested for a myositis-specific autoantibody because they can occur together. Myositis-associated autoantibodies are identified in about 16 to 20% of juvenile myositis patients. And the three most common ones I have here in this chart. So anti-PMCL is not as common, 3 to 5%, but it's associated with overlap syndromes. So these are patients that have myositis and another autoimmune disease, as well as anti-UNRP. Those are seen in about 5 to 15% of patients, and again, associated with overlap. Anti-Rho 52 autoantibodies seen in about 14% of patients, and these autoantibodies are more commonly associated with patients with interstitial lung disease and more severe disease, and more often occur along with anti-MDA5 autoantibodies and anti-synthetase autoantibodies in juvenile patients.